Hello again, and welcome to another episode of Doctor in the Dugout Traveling Roadshow. We're happy to be joined by you viewers today, and I'm thrilled to have as my guest one of our new associates at Hoag Orthopedic Institute, Travis Scudday. Travis, thanks so much for being here with us today.
Thank you for having me.
It's kind of fun having you aboard now as one of our colleagues, since you spent a year with us at HOI as one of our joint fellows. So why don't you tell the viewers a little bit about what the fellowship means and what kind of advantage is it to step right into the same environment where you did your fellowship year to start your practice?
Yeah, so just a little background. Orthopedic residency is 5 years, and then most of us are doing fellowships now. So I did a fellowship in hip and knee replacement, and I was lucky enough to do it at HOI. So that's a year spent dedicated to hip and knee replacement. And it's really amazing. You do 5 years of training, you think you know a lot, and then you sit down and really dig into the details of one aspect of orthopedics, and you just, the growth is pretty impressive. So I was lucky enough to spend a year at HOI working with multiple physicians there, learning their tricks, learning the tips, and then also the staff at HOI has been world-class to me, and having a year of experience as a fellow and then going right into as an attending has really made an easy transition to where I don't really have to worry about the small details that you do at a new facility. So
you alluded to the fact that after 5 years of orthopedic residency, you chose to do an extra year fellowship, as did I back in the Flintstone days when I did my orthopedic training. Mm-hmm. But back when I did it, only about 10 or 15% of guys who finished their residency programs were choosing to do a fellowship in sports medicine like I did or joints like you did. Now that number is a lot higher, isn't it?
Yeah, a lot higher, like 90%. From what I see, it's going to keep getting bigger. Especially depending on where you're practicing. So in a large metropolitan area like Orange County, you're going to have the vast majority of orthopedists are going to have more of a specialty focus, as in they did a 1 year dedicated to one part of orthopedics to really hammer out the fine details for that portion of their practice.
And overall, I think this is a very healthy trend, because over the last 20, 25 years, orthopedics has become much more subspecialty oriented, and I think it's a great thing for quality, for patients to be able to go to somebody who specializes in a certain niche. The old saying, jack of all trades, master of none.
Right.
I think we're really seeing that in orthopedics now, where somebody's got a foot or ankle problem, they go to the foot or ankle guy. They need a total joint, they go to the total joint guy or gal. I mean, I think this is a healthy trend.
Right. It's really interesting. You talk to some older orthopedic surgeons, and sometimes they look down upon the newer generation because we really try to stick into what we're good at. I think it's only natural. If I'm doing 10 to 15 knee and hip replacements a week, I'm probably going to be more comfortable doing them than a guy that's doing 5 a month. Right? It's just it's a natural thing, and to expect an orthopedic surgeon to be that locked in on every aspect of care, because also our breadth of knowledge has grown, right? There's been so many more research papers and articles published in the last 15 to 20 years that it's almost impossible to really stay on top of all that orthopedics has to offer.
But that said, a young guy like yourself still has to keep a little toe in the real world,
yes.
Covering the emergency room, doing all the bumps and bruises and everything else that comes in that isn't a joint replacement.
Exactly.
So let's scoot into your specialty now, because I know what you want to talk about today. Total hip and total knee replacement today is certainly a far cry from what it was 20 or 30 years ago. It's almost become so routinized, so routine. I mean, you see so many more people having hip and knee replacements today as opposed to 20 or 30 years ago. That's not just from the baby boomers and the fact that there are more people who need it, but I think our indications have changed. We're much more comfortable doing them in younger patients than ever before. Talk a little bit about that.
Yeah, the biggest change, in my opinion, in the last 10 to 15 years have really been besides the techniques and the pain control, are the implants. The plastics that we use are so much better. So if you would have had a hip replacement 20 years ago, your doctor would have said, this is going to last 10 years, hopefully, maybe 15. And usually the reason they failed was that the plastics wore out. The majority of hips were a plastic bearing with either a ceramic or a metal head, and the weak link was the plastic. Now our plastics are more 20 to 30 years. We recently looked at our plastics that we use most commonly at HOI, and we're seeing almost no wear. So it's hard to promise, but looking into the future, it's more of a 30-year joint. So then we can be more comfortable offering that to a younger patient who meets the criteria of decreased function, worsening pain, and if we think we can make them better, I'm not sure there's a need to make them wait 5 years and lose those 5 years of function because our parts are that much better now.
And talk a little bit about, I know a lot of people, our listeners out there, are worried about infection. Infection is something we especially worry about in orthopedic surgery. What kind of things have been implemented, especially at HOI, but probably in other places as well, but we've kind of made an art out of it.
Right.
What kind of things have we been doing to really minimize that infection rate? Because infection is the absolute killer of your surgical successes.
The bane of our existence. The one thing that keeps us up at night. So it starts from your preoperative visit, controlling risk factors that we can, diabetes, smoking, if you're severely overweight, all of these things that we try to tune people up before we offer a joint replacement. And then once you get into the process, we screen everybody for MRSA. So Staph aureus is one of the known bacteria. It lives in people's noses. We screen for that. If that's positive, then we hold off on the surgery. We get rid of the bacteria, and then we move forward. We do special wipes a few days before surgery, again trying to just decrease the bacteria burden that you have coming into the surgery. And then surgical things. So our operating rooms are equipped with special airflow. It keeps the bacteria away from the operating area during the case. We're giving antibiotics before surgery. We do our surgery in an efficient manner. We know that having the wound open for a shorter period of time, less risk of infection. Just kind of makes sense. And then our techniques as far as preserving as much soft tissue as we can, and then moving efficiently. Last is our wound care afterwards. We're using adhesive dressings that are put on in the operating room in a clean environment, so there's no need to take it off and change it in 2 days after. So with all these things, we've gotten our infection rate down to be extremely low numbers, less than 1%. But we're always striving to get rid of all infections, if we can.
Perfect world is a zero infection rate. We aim for it. I don't know that we can realistically achieve it. The other big thing that we've seen happen in the last couple of years is this move towards getting patients, first of all, out of bed right away after surgery, within hours usually, I know, at HOI, and out of the hospital faster.
Yeah.
I mean, a large number of the hip replacements are going home same day. Total knees, maybe a day or two.
Right.
Tell us a little bit about what kind of things have enabled us to have this enhanced recovery, this more rapid return to home and to getting back to life.
Right, so the enhanced recovery program allows patients to come in, have their surgery, and go home on the same day. The reason we like it, the patients like it, there are sick people in the hospital, even at an orthopedic hospital like HOI. The sooner we can get people out of a hospital setting or a nursing home setting, the less bacteria they're exposed to, the less chance they have an infection. So for that program, it's really all about preoperative expectations, pain control, and setting up therapy for home and any home care that is necessary. So for our knees, we have a pain catheter that goes home with the patient for 4 to 5 days. That has helped quite a bit as far as getting patients comfortable to going home the next day after their knee replacement. We use we call it multimodal pain control, many medications all from different classes, working in different ways to try to make the pain tolerable so patients can go home comfortably. Because while we want patients to go home, we also want them to be comfortable. We don't want them to go home and have to come back and say, my knee is hurting too much, I can't handle this. So we've been very successful. We have a very low bounce back rate of patients coming back, and it's been universally lauded from the doctor's side and the patient's side. Patients are definitely happy sleeping in their own bed, eating their own food, much more so than hanging out in a hospital bed overnight.
And I think we've changed our philosophy on this a lot too in the years, of not necessarily staying longer in the hospital so you're pampered, quote pampered, or going to a skilled nursing facility.
Right.
Where the facilities, I still say patients' homes are the cleanest, safest place
Yeah.
for them to be. They know where the furniture is, they keep their home clean, it's controllable. We can send therapy to their house, we can send home health aides to their house. We'd rather get them home in their own setting. I think people recover better in a place where they're comfortable.
Yeah, and especially interestingly, there's been a few studies have shown that there is an actual increase in your risk of infection and all-cause complications from going to these nursing homes. Now, sometimes they're necessary for social issues or other reasons, but we like to, as much as we can, avoid those. And you're right, getting the patient back home where they have the comforts that they would be used to, everyone's happier.
So last point, I know there's a lot of stuff out there in the news in the last 6 months, a year, a little longer about opioids and opioid use. Part of, some people are afraid to have a hip or knee replacement because they're saying, I don't want to have to take those medications. I don't want to get addicted to opioids. Just tell us a little bit about what we're doing to minimize the use of narcotics and opioids after the hip and knee replacements so people don't have to have that fear.
Right. Yeah, the opioid epidemic is an issue, and we know that patients on chronic opioids have higher complication rates. So it again starts preoperatively. If you're on a chronic painkiller, we ask why and try to get you to either a lower dose or completely off if we can. During surgery, we do things. We do a numbing medication into the joint that is replaced that helps you in the early period. We do nerve blocks, and then also using multiple medications that are not opioids. These are anti-inflammatories, muscle spasm medications, and good old-fashioned Tylenol, all to reduce the amount of opioids you need. For a modern hip replacement, it's very feasible to not take any opioids at all, and for knee replacement, maybe a very short course, and then be back to just over-the-counter pain medications.
Travis, thanks so much for being here with us today. To our listeners and viewers, you can learn more about Hoag Orthopedic Institute and Dr. Scudday at our website at orthopedichospital.com. Thanks so much for tuning in to us today. And as always, we're brought to you by the Hoag Orthopedic Institute, where we're the experts at getting you back to you. See you next time.